Thank you very much, Katarina. The honor is mine. It's a great honor being here at the Nobel Museum and in this beautiful hall of the Swedish Academy. And a great pleasure generally being in Sweden again. I'm going to make an apology first to all of you. I am blind in the right eye. I can't see you if I look forward. But since my visual field is full, I have no impression of anything missing, which means I may ignore or neglect people or things to the right. I will try and turn to you at intervals, but if I fail, you must excuse me. Before medicine, my special interests were in chemistry and in botany, and with both of these, I associate Sweden. On a previous visit, I went to Köping, and I saw the house and the apothecary of Scheele, the 18th century chemist who was a great hero of mine. And a couple of days ago, when I arrived, I went straight from the airport to Hammarby to see Linnaeus's house and garden. I grew up in a medical household. Both my parents were doctors, my older brothers were medical students, and for better or worse, the talk at the dinner table was always of patients and of cases. And both my parents were natural storytellers, but I think doctors often are natural storytellers. Much of medicine consists of stories. Their patients tell them stories, and they think about them and compare them with other stories. And storytelling is, I think, is very much at the heart of medical practice. And of course, all these stories are about people with a condition of some sort. My mother was a surgeon, and she especially spoke of patients with surgical conditions. My father was a physician. And the table talk was partly of what one could do for various problems, but equally it was of how disease and injury provided experiments of nature. Unfortunate, but providing a window sometimes into the way the organism works. It is difficult to dissect health and wholeness, but when something goes wrong, then it makes clearer the whole machinery. This was said very nicely by William Harvey in the 17th century, who discovered the motion of the heart. And he said, "Nature is nowhere accustomed more openly to display her secret mysteries than in cases where she shows traces of her workings apart from the beaten path." That's the only quotation I have. Although I first wanted to be a chemist and then a botanist and then a marine biologist and then a physiologist, I went to medical school with the thought that I would probably become a doctor. I remember none of the lectures which were given in medical school, but I remember all of the patients. In general, my memory is always for the singular and for a personal relationship. In a recent book, in a book which is to come on hallucinations, I give the story of a man I saw in 1958, which has remained perfectly clear in my mind for all these years. Seeing patients was crucial. The library was crucial. where one could wander around and read what one wished. I especially got attracted to case histories from the 19th century. Gowers, Charcot, and many others, case histories which seem to have a richness which has almost disappeared from the medical literature. These case histories, although they were perhaps 100 years old, seemed to me acutely relevant to the sort of patients I saw. They had not become obsolete. I think a good case history is timeless. Even a very old one, in the 1st century, Areteus gave descriptions of migraine and how patients might respond to migraine, and his description rings absolutely true 2,000 years later. Beside medical case histories, I read all sorts of other books, although I especially enjoyed memoirs by people who had been patients. One of them I read was a marvelous book by a Hungarian novelist, Karinthi, who had developed a brain tumor, which was finally operated on here in Sweden. He was conscious during the operation, as one has to be with many brain operations, and this is the first ever description of a brain operation by the patient. I was fascinated by an autobiographical novel called The Ordeal of Gilbert Pinfold. This is by the English novelist Evelyn Waugh. Evelyn Waugh drank heavily, he took sleeping medication, he took opium, he took a great many things. And when he went on a sea voyage to try and clear everything out of his system, he became psychotic, and he heard voices commanding him, seducing him, accusing him, embracing him. He never saw anything amiss, but the voices seemed to come to him. And I think this is a wonderful case history of a toxic psychosis written by a novelist who just has a genius for drama and dialogue, and I regard that as a history. Actually, I regard many novels as case histories. But of course, they are case histories without a plan. You never know what's going to happen, and typically with Pinfold, the story is full of surprises. I'm attached to my little bottle, and excuse me. And I'm also exceptionally clumsy, and I'm afraid I will knock over the glass or drop it or something. Years in medical school and residency seem to go on forever. But finally, in 1965, I had a final attempt at being a real scientist. I had a fellowship in neurochemistry and neuropathology, but my clumsiness caused a great deal of trouble in the laboratory. Much was broken, much was lost. And at the end of the year, they said, "Go see patients. You will do less harm." And so mine has been a clinical life ever since. I started with two groups of patients. One of them had migraine. I at first thought that migraine would be, such patients might be very dull, that migraine was just a headache, but I speedily found if I let patients speak and if I listen to them, that migraine could open out into a whole encyclopedia of neurology sometimes. But also, I had to remember that this was a human being, an individual, who was in trouble and suffering, and the intellectual interest of what they were describing and the feeling and moral responsibility for their welfare had to be balanced. In a way, my apprenticeship in medicine was these patients with migraine. I'll tell you one story to illustrate how patients educate one. I saw a man who described to me attacks in which he would see a brilliant zigzag to one side, followed by a headache and vomiting. And this had not been diagnosed, and I said, this is classical migraine. I was a little puzzled when he said that he only got migraines on Sunday, although I was to find this was not an uncommon pattern to have a sabbatical migraine. And this especially for people who work very hard during the week. And when the weekend comes, instead of enjoying leisure, they may be punished with a migraine. But I said to him, don't worry, treatment is easy. We have a tablet which you can put under your tongue as soon as you see the zigzags, and this will stop the attack developing. The next week, he phoned me up joyfully. He said, this has happened. He said, doctor, you're marvelous. And I sort of felt pleased, and I thought, isn't medicine easy? I also thought, is that all there is to it? The next Sunday, he didn't phone me up, and I was puzzled, and I phoned him up, and I said, how are you? What's happening? He said he'd taken the tablet, and the tablet had worked, and yes. He said no one came to visit him. Normally, when he had a migraine, family would visit, friends would come in. He was surrounded by an atmosphere of sympathy, but no one visited him, and he felt lonely and bored. And he also looked a little apprehensive. He said, something will happen. I said, nonsense, the tablet will take care of it. The Sunday after this, his sister phoned me up. She said that her brother was having a terrible attack of asthma, a status asthmaticus, and she sort of implied that it was my fault. And when this was over, I again talked to the patient, who told me that when he was a little boy, he would have attacks of asthma on Sunday, but when he was about 10, these had apparently been replaced by attacks of migraine. I hadn't got this information. I narrowed my questions too much. I should have tried to get a picture of his entire life, whether it was, because one does not know in advance what may be relevant. I said, well, don't worry, we can treat the asthma. And he asked me a very strange question. He said, do you think I need to be ill on Sundays? Now, my training had been very physiological, but I was taken aback by this question, which seemed to relate to the whole rhythm of a life and the economy of an individual. And I said, well, let's consider it. Let's explore this. In the next 6 weeks, as we considered it, he went back to migraine, but his migraines got less and less without any medication. And so this opened up for me some of the complexity of what can happen with patients and physicians. I read a lot of the medical literature, so-called. I read many papers about migraine, which seemed to me, on the whole, although they often had interesting experiments, to convey very little of the complexity and richness of the experience. And then I started thinking back to my medical student days when I would go back to 19th century texts, and in the rare book library where I worked, I found a book dating from 1873 called Megrim. This was the old English spelling of migraine. And this was a book which was wonderful in its narrative power. Thackeray or Trollope or Dickens would not have been ashamed of it, but also in its sympathy, in its imaginative, empathic entrance into the minds and lives of patients, and the conditions of their lives. He made a point, for example, of saying migraine is not confined to the rich and idle. It can inflict itself on the poor and laboring through long hours and insufficient fresh air, and so forth. I felt when I was reading this book that I was with Living, that I was seeing his patients with him, and this book was instrumental in getting me to write my first book. I'm not sure that I would have written it had it not been for the inspiration of this book, Megrim. At the same time as starting with my migraine patients, I went to another hospital in New York. I realize I'm so overreacting to saying I might ignore you that I'm ignoring you instead. I went to a hospital in the Bronx, a chronic disease hospital, and when I got there, I was startled, actually, when I first visited the hospital, to see dozens of patients, sometimes completely motionless in strange statuesque positions, unmoving, unspeaking. I had never seen anything like this. I was a little reminded of catatonic patients who may be seen sometimes in psychiatric hospitals, and yet this was different. And I learned that some of these patients had been in the hospital for 30 or 40 years, and that all of them had had a disease in the time of the First World War, and immediately afterwards the sleepy sickness or encephalitis lethargica. This disease was often fatal at the time, but other patients recovered, but then later moved into this strange state. I had no idea that such patients existed, or that such a state could exist. There had been no medical literature on such patients since 1935. I didn't know what to make of them. I wondered what went on inside. The nurses often know patients much better than doctors. The bond may be much closer. The nurses told me that these patients, in fact, were intact intellectually, but imprisoned by their Parkinsonism and their catatonia, but also that they could be released sometimes, released especially by music. And some of these patients, unable to take a step, could dance, or unable to utter a syllable, could sing. And music would liberate them while it lasted. But when the music finished, when the music was over, they reverted. At that time, in 1966, there was no known medical treatment, or should I say no published medical treatment for patients like this. But an astonishing experiment had been going on in Long Island, an experiment really inspired by the work of Arvid Carlsson, who in the late 1950s showed that the Parkinsonian brain was low in a transmitter called dopamine, and that if one can't give dopamine, but that if one gives a precursor, L-Dopa, then dopamine may be made in the brain, and this may be helpful. This remained in a way theoretical for some years because people only used very small doses, a few milligrams of L-Dopa. But my colleague on Long Island used grams instead of milligrams, audacious man, and there were amazing results. And in February of '67, these results hit the world. There are now millions of patients on L-Dopa, which has really been a miracle in extending life and making life better. And all of this again stems from the work done here in Sweden in the late 50s by Carlsson. Well, here I found myself in a different position. When I saw patients with migraine, I worked in a clinic. The patient would come in, see me, they would go home. These patients were all in a chronic disease hospital. I moved, so I lived next door to the hospital. I started them on L-Dopa in 1969, and its effects, as I describe in my book Awakenings, were both wonderful and terrible. They were very, very complex. While I was trying out this medical treatment, on the one hand, I was concerned that these people who had often been isolated and abandoned and cut off from human life for decades needed contact. How might they respond if the L-Dopa worked? I went to great lengths to bring them together into a sort of community and to contact long-lost friends and family. And so this was as much, one was as much engaged on the human side as on the purely medical or medicational side. The most overwhelming medical and human experience of my entire life, I think, came in a few months in 1969, when these people who had been immobilized and isolated for decades often very suddenly came to life, but found themselves in a world very different from the one they had lived in, because many of them had dropped as through a vacuum from the 1920s to the 1960s, from their 20s to their 60s. I spent all my time among them. I tended to carry a notebook in one hand and a camera in the other hand. I felt it essential to record as fully as I could, and if I could do so without offense and unobtrusively, to record what I could of what was happening. And I also encouraged the patients themselves to keep notebooks and journals, though many of them spontaneously wanted to do so because they realized that something fantastic and unprecedented was happening with them. And they said to me very strongly, tell our story. They had the feeling that they had been abandoned and unknown, and that their stories should be told. And to some extent, I tried to give voice to these patients and to use their own words when I could. I tried to compress some of what I saw into traditional medical papers, but the situation seemed to me too complex and to demand a different sort of book. And here I was reinforced by W.H. Auden, the poet, who had come along to the hospital and who had seen this. And Auden's father was was a physician in England who had been one of the earliest describers of this disease in children. And Auden said strongly to me, you will need a book which extends beyond the clinical. It may have to have poetry, philosophy in it, whatever. I was also implicitly encouraged by an extraordinary book I had read in 1968 by the Russian neuropsychologist A.R. Luria. It was called The Mind of a Mnemonist. A mnemonist is a man with a prodigious memory who makes a living by feats of memory. But I started reading this book thinking it was a novel. It seemed like a novel for the first 20 pages. And then I started to realize that in fact it was a case history and a case study of extraordinary detail, but with the drama and the sympathy and the human feeling of a novel. It was, and when Awakenings was published, I dedicated it to the memory of Auden and to A.R. Luria, because they were really, I felt, my mentors, my inspirers. And I took great liberties with language. Liberties which I think infuriated many of my colleagues, so that the book did not receive any medical reviews whatever, although it was pleasantly received by others. There was a talk on the radio when the book came out in '73 between Alvarez, who was a poet and critic, and a neurologist. And in particular, the neurologist said he thought the book had some interest, but that it was far too detailed. He said it was full of superfluous detail. I had the opposite feeling. I felt it wasn't detailed enough. I don't think anything can ever be detailed enough. I think to get the density of reality, for example, of what it's like to be Parkinsonian, or indeed what it's like for someone with Parkinson's to get up from a chair and walk across the room, you would need 30 pages of dense description. And of course you would have to be highly selective at the same time. But I will come back to this business of the density of description later, because I think it is this crucially which distinguishes case histories from some of the approaches which are tending to replace it. I've compared case histories to novels, but specifically they have some resemblance to detective stories. Instead of a crime, you have a disease, but there are clues, and you are looking for a solution. The solution may take many different forms. Sometimes it's a medical or surgical solution, sometimes there is a natural resolution, sometimes it's a case of the person having to adapt himself or herself to the disease, or to adapt the disease to themselves. One constantly sees the relationship and the interaction between the person and the condition. And Osler, the great Canadian physician, would always stress this and say, ask not what disease the person has, but what person the disease has. Obviously, you do both. I never found it possible to write case histories or even to write my notes straight away. I would jot down a few things and then I would go for a walk. The Botanic Garden in New York was right opposite my hospital, and I would go for a walk and lose myself there for an hour, but when I came back, a narrative would have formed in my mind, which embedded what I had learned, but also in a way went beyond this and transformed it and sometimes became a sort of essay or exploration as well. Awakenings was written in 1973. In the ensuing years, I've seen patients of every sort. One comes to my mind. She was a patient in the same chronic disease hospital. Sometimes I would take medical students around the hospital so they could see patients and learn. And this particular patient really enjoyed teaching the students. And she had a rare disease called syringomyelia, in which a cavity forms in the spinal cord. It's a rather obscure disease, and she would say, don't think of syringomyelia as a small paragraph on page 1100 in your textbooks. Think of me. Think of the story I've told you. Think of the way my head is tilted to one side, how my arm hangs down, how it has a large burn here because I had no feeling of temperature and pain and leant against a radiator and only realized what had happened when I smelt burning flesh. She would say, remember me. She herself would essentially and consciously be a case history. And sometimes now when I see my former students who are themselves professors and retired or grandfathers, all of them remember this patient, Goldie Kaplan, and her arm with a big burn on it. Now in my hat book, I describe this patient, Dr. P, who had become unable to recognize anyone or anything visually and made absurd mistakes all the while. And it was also very difficult for him to do things like putting on his shoes or buttering the toast. But he was a singer, and he had found that he could have a dressing song, a toast buttering song, and many sorts of songs. And one way and another, he would have been entirely helpless without having these songs, but he was able to sing himself through the day. Incidentally, years later, an opera was made of the man who mistook his wife for a hat. And in the opera, which I hope comes to Sweden one day, his music is all Schumann. I seem to see a lot of musicians. Perhaps they gravitate to me because it's known that I'm interested in music. In the current book, The Mind's Eye, I describe a pianist, Lilian Kalia. I feel free to give her name because her husband and her daughter and others, her husband and daughter, have said, use her name. Normally, I would conceal someone's name unless I get very explicit instructions to the contrary, and unless I feel they would be comfortable. I don't want to mention someone's name and have them regret it later. But here, I was allowed to use her name. Lilian Kalea was a brilliant pianist. She said she could read any Mozart piano concerto at sight easily, but one day in 1991 at a concert, when there was a sudden change from one piano concerto to another one, she glanced at the score just to remind herself of it, and she found it unintelligible. She could see that it was music, she could see that there were staves and blobs, notes, but she could make nothing of it. She wondered if it was something wrong with her eyes. She had a cold at the time, thought it might be a cold, and 2 days later she was able to read music in her normal way. But this inability to read music, this Alexia, as it's called for music, became worse and worse, and after 3 years was joined by an Alexia for reading print or writing. She was able to write, and in this condition, typically, people are perfectly able to write, but cannot read even what they've just written. And she wrote me a letter in 1998 describing things and how, indeed, the problem of recognition had gone on still further, so that it was not merely print which was unintelligible, but everything around her. And she came to see me. Delightful, warm, intelligent woman. Poignantly but bravely aware that something was happening to her brain, slowly but inexorably, in particular to the visual parts of her brain. In many ways she had adapted. She was still giving concerts, giving master classes. She found that her musical memory, which was remarkable to begin with, had become even better. But I couldn't imagine how she got about. I had to make a house call. I like to make house calls. I think one can't often get a full idea of what a patient is like without going to their home, seeing how they live, seeing their relatives, perhaps seeing them in the neighborhood. I went to her apartment, the apartment she shared with her husband, who was also a great pianist. The house was very crowded with mementos of every sort, cluttered, and I thought would be a nightmare for someone with agnosia, someone unable to recognize things. But Lilian had reorganized the entire household in terms of the color and shape and position of objects. And in a way, she could find things in the same way as perhaps an illiterate person could find something in a book. She had a very acute sense of color and shape, and location and association, and this had to do instead of... Now, there had in fact been a medical article. There is a neurology article, a published article on Lilian describing her as a case of visual agnosia due to damage in the posterior parts of the brain. But the article completes itself with listing her symptoms and giving a diagnosis and showing a PET scan of reduced metabolism in the back of the brain. There is no intimation of what sort of life Lilian led. And it's exactly the sort of life which people lead when something happens to them. something out of the ordinary, which intrigues me and I think has to be told in a case history. So in the recent book I mention another man, a novelist, who in a way had an analogous experience. He lives in Canada, and one morning he went downstairs, he had breakfast, he felt fine. He opened the door to get the newspaper, the Toronto Globe and Star. It looked normal from a distance, but when he brought it closer, he found it unintelligible. He thought for a moment it might have been in some other language, perhaps Serbo-Croat. He wondered for a moment whether this was a special foreign edition of the Toronto Globe and Star, published for an ethnic minority in Toronto. His next thought, because it was near his birthday, was that this was a joke which had been arranged by his friends. But when he opened the paper out and found even the minutest advertisements were unintelligible, he realized that something had happened. And he partly realized what had happened because he had read one of my case histories, a case history I will mention to you of someone who had such an Alexia briefly. This man who is a brilliant writer of detective novels and a man of great literary culture generally, went into his library and found that every book he opened, whether it was in English or French or German, only had this strange-looking, unintelligible script. He found this very terrifying. He didn't know what might happen next. Would this proceed to complete blindness? How could he continue as a writer and a reader, a most passionate reader, if he couldn't make sense of this? At that time, he hadn't discovered that he could still write. Well, he was found to have had a small stroke in a different part of the brain on the left side, and there was a little recovery from the stroke, but not much. Sometimes he would recognize a letter, and after a while he could recognize individual letters. So he might recognize a C and an A and a T. Oh, cat! He could not see it as a word. Similarly with large numbers, he couldn't read 107. He would read a 1, a 0, a 7. But then, strangely, he found that he was beginning to read again, slowly, and he thought he must be recovering. He went back to his neurologist, who tested him and found not a trace of recovery. What was going on? He had found in the meantime that he could write perfectly well, and he had fallen into the habit, first conscious and then unconscious, of copying what he saw with his hand, essentially writing it with his hand. And then, and this happened without his collusion, but just by a wonder of nature, his tongue took over the function, and as his eye looked along a line of print, his tongue would trace the letters and the words on the back of his teeth. So he was reading with his tongue. And he mentioned to me that on one occasion he had a sore throat and couldn't use his tongue for this, and the sore throat made him illiterate for a week till he recovered. Now, this condition of alexia, sometimes called alexia sine agraphia, inability to read without inability to write, This was described again in one of these wonderful, and one of the most wonderful 19th century case histories by Desjardins. Desjardins' paper is about 40 pages long. My neurological colleague, who had found awakenings too detailed, would have said the same in this paper, but in fact everything rings true, and I could see all the similarities to my patient. When Desjardins' patient died, an autopsy was done, and Desjardins was able to inculpate a small area in the underside of the temporal lobe on the left. This same area has been found damaged, whether by a tumor or a stroke, in every patient who gets Alexia. This would seem to be the center for reading, or the center for written letters. But one would say, how can such a center be? How could such a center develop? Because writing is only 5,000 years old, and evolution does not move at that rate. This sort of thing became a source of dissension between Darwin and Wallace. Wallace would fully admit the similarity of the human form and the human brain to those of apes, but he also felt that there was an immense reservoir of unused potential had been implanted by the Creator, which perhaps millions of years later would be released. Darwin had, in a way, an analogous idea, but with no creator. Darwin would believe that an area had developed, a visual area, for the recognition of natural forms, of landscapes and things, but that this area might be redeployed, might be given another function, for example, to read. And so here, I really never thought about the relation of culture and nature in enough detail until I had this patient and started to wonder about reading and writing, or for that matter music, or for that matter any artistic or cultural achievement. I should be looking at the watch, but, well, I will. I want to mention two other patients, because they come to my mind vividly and with affection. I can't write about a patient unless I write with affection and with some warmth, and there's always some emotional rapport between us. I got a letter early in 1986. I now get literally thousands of letters, and some of my communication with the world and finding patients happens through correspondence. Sometimes there's just an exchange of letters. Sometimes I'm able to see the patient. Lillian, who'd written me a letter, and this man, Isaacson, an artist of some eminence, wrote me a letter saying that he had had an automobile accident a few weeks earlier. He'd been unconscious for a while and had a gap in his memory, and when he came to, he found on his desk a police report which he could not read, which he thought might be in Greek or Hebrew. This gave rise to the Serbo-Croat Association, but also Isaacson found that his studio, full of brilliantly colored paintings, had lost all their color. He could only see in black and white. He was horrified by this. He thought it would be the end of him as an artist, and he also found he thought everything looked hideous. When he went home, hoping to receive comfort from his wife, she too seemed to be a statue of grey, and his own hands were grey. When he tried to imagine an orange, he couldn't. Colour had been drained from imagination and memory, as well as from perception. At that point, he came to me. He said in his letter, had I ever encountered this before? Could I suggest anything? I wrote back and said I'd never encountered it before, but that I had heard of such things. Again, I keep referring to the 19th century. There are wonderful 19th century descriptions of suddenly losing the sense of colour, sometimes in just half the visual field, sometimes the whole visual field. We know, again, the parts of the brain which are involved, but it's one thing finding they're damaged, another knowing what to do about it. What happened with Isaacson was, in a way, a sudden change of aesthetic and identity. He was driving to his studio one day, although he hadn't been able to paint anything for some weeks, and he saw the sunrise, and for him, he said it was like a huge nuclear explosion in black and white. It was immensely dramatic, and for the first time, he felt the force of a different sort of vision. And this really released a new stage in him in which he did the most wonderful paintings, not using any colored pigments. He had tried for a while to use colored pigments, but his friends told him he was producing nonsense. And there was an exhibit at which some of his new paintings were shown, and critics remarked on that the old man had now entered a new phase of art, which he had, but it was a phase this was his creative use of a perceptual disaster. Although by this stage, he no longer thought of it as a disaster. He felt that his vision had become more refined and more delicate, that he had a deeper appreciation of texture and movement and depth, and that perhaps he had been distracted by colour in the past. And when a suggestion was made that it might be possible to retrain or to train another brain area to construct colour, he said that was very interesting, but he was not interested. He said, if you had been able to do this a week or a month after my accident, I would have embraced you. He said, now I live in a different world and colour would be irrelevant. I found this very amazing, although subsequently I was to visit an island in Micronesia where 1/10 of the population are born without colour receptors in the eye, and there is not only no personal, but with them no cultural knowledge of colour. And I went there, I think, with a certain feeling of pity for these people, but I was soon to realize that, on the contrary, the feeling of pity went the other way. They thought I was a poor fool, beguiled by colour, and that they were visually much more in touch with reality than I was. I'm going to mention one more patient and then I will wind up. And here again things arose through a letter, actually through a phone call, about a blind man, a man who had been essentially blind since infancy, and the suggestion that surgery might restore vision. He had very dense congenital cataracts, and it was really not known what sort of shape the retina would be in. Now, however, by the time I heard about this, he'd already had surgery, and I was given a very detailed description, and by the man himself as well as by others. His father-in-law was a pastor, and so was his wife. There was a strong religious atmosphere, and there had been some hope that there might be a miracle like those in the New Testament. He'd had surgery on one eye, wore a bandage for 24 hours, and then the bandage was removed. And everyone waited either for a hallelujah or perhaps I can't see anything. Neither of these happened. Virgil seemed to be gazing blankly, not focusing too well, until the surgeon said, "Well, what's going on?" And when the surgeon said that, Virgil's gaze focused in on the surgeon's face and mouth. He said later that he knew voices came from faces, so that the voice told him where to look. But he did not see a face. He saw an abstract of color and borders juxtaposed and moving strangely. He could make nothing of it. He thought, this is a face? Is this what sight is like? And this was how it was for a man who had been deprived of those essential weeks in early life when correlations are made and when things become recognized. So at first, this man had sensation, but no perception, or very little perception. He could perceive color and movement, but he found this very disabling. As a blind man, he was very fluent. He knew how to behave as a blind man, how to walk, how to use his stick. He was a masseur by profession. When he could see, he was horrified when he did massage on people, because he was now conscious of blemishes and colors on the skin, which he had not known about before. Now, this, I went back and I looked at the literature. This is at that time, only a dozen or so cases had been reported over the centuries, the first one being in 1728. And the first one, indeed, was published partly as an attempt to resolve a philosophical dispute between Locke and Leibniz, and also a question asked by William Molyneux, the Irish philosopher who had a congenitally blind wife. And Molyneux said, if someone had previously recognized a shape, a glass, a cylinder, a sphere by touch, would this knowledge transfer itself to vision? Leibniz said yes. Locke said no. Locke was right. There have been major problems in every case with people in this situation, and some of them, like my own patient, have longed for blindness. And so this is an immensely complex thing. You think you're giving the gift of sight to someone, I should say that now there are some technical and other advances which may make it more possible and more prudent to undertake. But one really, it's not just a question of finding a pathology, finding a problem and treating it. You have to see how the condition is embedded in a person's life and in the context of their life, and measure everything in relation to that. Now, in 1980, a hideous book was published in America. It's known for short as called the Diagnostic Statistical Manual, or DSM for short. And this gave criteria, major and minor criteria sometimes, lists of criteria for the diagnosis of every condition. The DSM is now about to come out in its greatly expanded in its 5th edition. A doctor, I don't know how it is in Sweden, but in America, a doctor cannot get paid for seeing a patient unless he makes a diagnosis and lists criteria precisely as the book says. And increasingly, in medical charts, you no longer find the detailed descriptions and case histories you used to. You just find a nasty little list of criteria. When I arrived at the chronic hospital with the awakenings patients, there were beautiful charts going back to 1920 sometimes. I could already get a rich picture of how it was with the patient. And when I worked at a psychiatric center, again, there were almost novelistically rich descriptions. All these have vanished. There is the notion that information and a list can take the place of a narrative. I think this is a dreadful and very dangerous replacement. The DSM criteria may be wrong. They may not be appropriate. In any case, you cannot get the fullness of a medical condition, let alone of a life with that condition, from a list. You have to have a narrative. You have to have a case history. When I look at charts now from the 1980s, the 1990s, I really have very little idea of what to expect. So I think I need to wind up. I've said that I think that case histories are timeless. They do not become obsolete because human conditions and the way in which human beings respond to these conditions have been much the same for thousands of years. We have wonderful case histories from the past, but we are not now giving any to the future. I think that there is a notion that with advancing technology, with CAT scans and functional brain imaging and everything else, it is superfluous to make such descriptions. This is not so. All the other laboratory tests and all the other criteria are complementary. There is no substitute for a case history, and this essentially is what I came here to say. Thank you very much.
Thank you very much, Oliver, for an extremely nice lecture. We'll now have some time for questions from the audience. So I just will ask for the microphones coming down. Okay.
From heaven.
Yes, from heaven. So please, feel free to ask questions.
I'm rather deaf, so I'm hoping these ladies will assist me.
Yeah. Okay. Over there.
Thank you very much, Dr. Sachs, for a wonderful lecture. I got very interested about what you said in relation to what role culture plays in, for example, amusia. And would a person, a person in the Serengeti in Tanzania, a Maasai, would he have amusia if he cannot distinguish between the singing birds or the leopard noises? How would it be amusia in a person that doesn't have music as an intellectual and cultural part?
The question is, how much does culture impact amusia? And would someone growing up in a different culture have amusia?
Culture will certainly impact Alexia, and with bilingual people may be alexic in one language and not in another. Amusia seems to be a much different and much broader condition in which there is no perception of melody and sometimes no perception of tonality or pitch. I'm not sure whether culture impacts that, but it certainly impacts the opposite of this. That's to say that absolute pitch, which is very rare in most cultures, is very common in Thai and Mandarin and other cultures where there's a tonal language.
Thank you very much for a very extremely nice lecture. I wonder, once upon a time, the psychiatry and neurology was one subject. What would you say is in the future? Because since then, psychiatry has been very subdivided, and also neurology. For the future psychiatrists or neuropsychiatrists, what do you think would be advisable?
Well, this is a very deep and fundamental question. It was not uncommon in the 19th century for someone to be both a neurologist and a psychiatrist. Freud himself was a neurologist, and a very good neurologist for several years before he became a psychiatrist, and he attempted in his project in 1896 to find some neurological correlates for various psychic functions. He then realized that this attempt was premature, and he threw it away, and, well, he didn't publish it. It's been published posthumously. But he certainly felt that everything in the mind must also in some form be in the brain, and that if psychoanalysis or other psychiatric methods worked, they would alter the brain as well as the feeling and the thinking. At the time I became a physician, and when I went to America in the 1960s, there was psychoanalysis was held in great esteem, and there was very little of what we would call biological psychiatry. But things were already beginning to change then, because the tranquilizers the first tranquilizers came out in the 1950s, and as Carlson showed, these could have an effect on dopamine levels and on mental illness of one sort and another. Now in America, the pendulum has swung very strongly towards biological psychiatry and the use of medications, and there is less in the way of psychoanalysis or supportive therapy. I think there has to be a balance, that no approach can be purely chemical. In particular, I've been fascinated sometimes by the therapeutic power of a community and certain forms of living. I was amazed some years ago when I was in Belgium to go to the little town of Geel, which for 700 years has opened itself to mad people, and who can enjoy a pretty full life. I think that a current problem in the States are post-traumatic stress reactions, which can often be psychotic and almost like schizophrenia, and have dangerous sudden flashbacks. And there are certainly very clear-cut cerebral changes, especially in the temporal lobes, in people who have these stress syndromes. So in some ways, I think neurology and psychiatry will draw closer, but I think there will always have to be two separate languages. It's not entirely useful to put the language of emotion and thought into physiological correlates, even if you can do so. So I think in this sense, a sort of dualism will always remain.
Thank you for today, and thank you for telling us about Virgil again. And it brings up a recent story in the news to mind about patients in the UK are having an implant into the eye. They're functionally blind, and this implant is transducing the light signals to their optic nerve. And so clearly we're making progress on the brain-machine interface, but do you think we're doing enough for the mind-machine interface? And how will this work?
Well, I think you'll probably get a better answer to this in 2030. It is the ability to simulate vision is very remarkable and being developed all the while. But on the motor side, great advances have been made with interfaces so that people who are paralyzed or perhaps locked in and unable to move or talk may now be able to move a prosthesis or a small pointer by thought alone. I think brain-machine interfaces of every sort will be developing in a way which holds great promise and maybe great threat as well. Almost everything which holds promise holds threat. One knows, for example, that one's known for 50 years that if electrodes are implanted in the so-called reward centers of the brain in a rat, the rat will be compelled to press a lever again and again, not sleeping, not eating, and stimulating itself till it dies. And perhaps there are certain human addictions which are rather similar. Although deep brain stimulation can also be enormously valuable for people with Parkinsonism, Tourette's syndrome, epilepsy. Again, a moral question sometimes comes up about enhancement. If medicine moves from curing people to enhancing people, providing some people with super memories or super speed. But as I say, I think we are on the brink. We're still some distance from these questions, but if we're if we are around, if the planet is around in 2030, I'm sure you will see a very different world, especially in brain-machine interface. Is now having
active.
Yeah, right.
Thank you very much for your speech. As I understand you, you have talked about people with handicaps who have themselves they have been rehabilitated themselves. Is there something you can learn from that in order to treat other patients? The salutogenic factors that they have come up with themselves. Is there something you can generalize from that in the treatment of people who don't? You have talked about people who have rehabilitated themselves from serious injuries in the brain, and they don't need treatment because they have made it themselves. Is there something you can learn from them in the treatment of other people who don't rehabilitate in that way?
For people who adapt and rehabilitate themselves, can we take a lesson for others?
Oh, yeah. Well, I think we can, and very strongly. And I think one of the functions of the physician, but for that matter also the physiotherapist, the nurses, friends, anyone who has contact, is to try help discover other ways of living for the patient. And I think even if an illness is incurable, which sadly seems to be the case often at present in neurology, there are always better ways of living and coping, and often very, very unexpectedly, one of the patients I talk about in the new book is a woman who lost the power of language, who became suddenly aphasic from a large stroke. But she is a sort of genius of gesture, both of recognizing others' gesture and gesturing herself. And for example, although gesture is not a language but only a code, it is we have learned from such patients that that the power of gesture, recognizing gesture, can be heightened in everyone and should be in people with aphasia. Again, people who have aphasia may be able to sing perfectly well, and moreover to get the words of a song. This itself may be reassuring, because it shows that language is there, even if it is only embedded in a song. But the song itself can act as a sort of bridge back to language and back to a very radical adaptation in which previously silent parts of the non-dominant hemisphere of the brain become capable of language. And but the use of song and the use of gesture came from patient experiences and can be generalized.
Thank you very much. I have a question considering how most of the stories you tell are, as you described, very descriptive and narrative in nature. And that's not really how science is done these days. In fact, when you try to publish scientific work, often the word descriptive is a death knell for getting a paper published. So what do you think about the state of modern medical research?
Death knell. What do you think of the state of medical literature?
No, of medical research.
Medical publication.
All right. Well, I think the state of medical research is wonderful. I think that the increasing standardization of presentation in an acceptable scientific paper, while it has many advantages, may also do harm, and the offhand, the only way I know of dealing with this is to write not only papers but books as well, in which one has more freedom.
Well, thank you. And I just want to ask you, what should we think of if we want to write case histories? You said you need to let the plot come to you through a walk in a botanical garden or something like that. You need to be affectionate about your patients, and you need to have some density in your description. But is there anything more that we should think of if we want to write case histories?
I think that all of these conditions can provide different perspectives into understanding, into the nervous system, and I enjoy seeing a variety of patients, and there are all sorts of subjects I've never written about. For example, pain. I hope I can continue. I have a book which will come out about hallucinations, but I hope I have, as I approach 80, I just hope I have more years and the health to see more people and write about more conditions. I'm never bored by neurology. It is full of enchantments for me. It is fun. It is full of surprises, as well as frustrations and sadnesses. But it's a very full life. And whereas, say, Chekhov could say literature is my mistress and medicine my lawful wedded wife, for me, the two of them are wedded together from the start.
Okay, over there, and we will close the question session after that.
Do you ever think that we will get to the point where technological means of looking at the brain and what is happening in the brain will be able to at least assist in diagnosis of disorders like ADHD or Asperger's?
Make a diagnosis of something like ADHD or Asperger's?
I think in principle, yes, the sort of diagnostic algorithms are already used, whether by human beings or computers. I mean, in a certain sense, we are already behaving like machines when we use these diagnostic algorithms. But but I think one needs to say that medicine doesn't end with the diagnosis. It sort of starts there, and I cannot imagine a fuller picture of people's reactions. Although it has to be said that maybe in some ways I'm making too much of the biography and the extended case history. I remember going back 50 years to the time when I saw migraine patients. Some of them would say, why are you asking all these questions? Why do you want to know about my life? Make a diagnosis and give me a tablet. And I would say, go to my colleague in the next room. He's your sort of doctor. But other patients would come to him and feel frustrated that they weren't understood, and he would refer them to me. I think one needs sort of different approaches for different patients.
Okay, just one last question then. Christian, over there.
Yes, thank you for a brilliant lecture. What do you think about the impact of a new pharmacological product, for instance, from Lundbeck?
What do you think about the new pharmacological substances? The new ones, the new pharmacies.
New pharmacological substance.
Lundbeck, that's a famous Danish medical company.
Well, I have no idea of the specifics of this company. It is very important to have elaborate, detailed testing of new medications before they are let loose on the public. And there have been tragedies because some medications get out too quickly, as for example with the medication thalidomide, and hundreds of people were born without arms or legs as a result of this. This didn't happen in America, where the monitoring was slower, but sometimes the monitoring can be too slow. I see this with many of my patients who get medications from Canada or Mexico because they're not available in the States. But it is crucially important, for physicians and others to test every medication and not to be under any pressure from the company, but to declare their interests. One must have impartial, neutral, unbiased tests of every drug. That's all I can say.
Okay, then I think we close the lecture, and once again, thanks Dr. Sachs very much.